Hello, everyone, and welcome to the April PQA Quality Forum Webinar. My name is Amanda Ryan, and I am PQA's Director of Education. Today's topic is implementation of sustainable social determinants of health programs in community pharmacies. As usual, I would like to call your attention to three housekeeping items. First, attendees are encouraged to ask questions during the presentation, and you can do that by using the questions panel that's located on the right side of your screen. We will have time for extended Q&A today, and I will read the questions aloud for our speakers to answer. Second, the webinar recording and the slide deck will be available to PQA members within the week following the presentation, and that will be in the Member Resources section of the PQA website. And then finally, I would like to encourage all attendees to complete the quick 1-minute survey that will appear at the conclusion of the webinar. PQA would like to thank PerformRx for being an educational sponsor for this quality forum today. Thank you, PerformRx, for your support of PQA today and throughout the year. You can learn more about PerformRx at performrx.com. It is now my pleasure to introduce our speakers. First is David Jacobs, who is an assistant professor in the Department of Pharmacy Practice at the University of Buffalo School of Pharmacy and Pharmaceutical Sciences. Dr. Jacobs' research is focused on pharmaceutical health services and implementation science with an emphasis on multidisciplinary and collaborative research strategies. Also joining us is Dr. Christopher Daly, who is a clinical assistant professor also at the University of Buffalo School of Pharmacy and Pharmaceutical Sciences. His academic and research passions are innovative community pharmacy models, entrepreneurialism, social and administrative pharmacy practice sciences, and clinical-based outcomes research. Next is Heather Jarvis, who is a PGY1 community pharmacy resident with LNS Pharmacy in association with the University of Missouri-Kansas City. Her current projects in community pharmacy include the incorporation of social determinants of health, implementing a self-monitoring blood pressure program, implementing a behavioral health outreach service, and researching reimbursement for other clinical services. And then finally, Amanda Foster is a postdoctoral clinical research fellow with the University of Buffalo School of Pharmacy and Pharmaceutical Sciences. She focuses in pharmacy health services outcomes and research. Dr. Foster's clinical and research interests in outpatient pharmacy include transitional care, geriatric pharmacotherapy, diabetes management, and social determinants of health. I want to thank all of you for being with us today, and with that, I will turn the floor over to Dr. Jacobs.
Thank you for the introduction, Amanda. We really appreciate it. So just to start off with a couple of disclosures, support for the development, implementation, and research surrounding these projects were partially supported by the Community Pharmacy Foundation, and work for the CPESN Missouri components of the project were also partially funded by the Health Resources and Services Administration. So our learning objectives today, what we'd like to do is first define social determinants of health and how they really apply to the community pharmacy setting. We'll then go into discussing some of the new roles for pharmacy staff within a SDOH program in community pharmacy, specifically reviewing the roles of community health workers and social determinant of health specialists. Next, we'll go into specific examples and pilot programs of SDOH related programs, and then discuss potential sustainability models of these programs in community pharmacy. So let's jump into it, and first let's just define what are social determinants of health. And the WHO defines them as the conditions in which people are born, live, learn, work, play, and age that really affect a wide range of health risks and outcomes. And in the US, these conditions are placed into 5 categories, the ones that you see before you. And these broad categories reflect really several key factors such as social exclusion, lack of social support, difficulties with housing or transportation, access to healthcare, among many others. And these factors are really being increasingly recognized as drivers of healthcare utilization and costs. Now, community pharmacies are ideally placed to really play a major role in addressing social determinants of health, as they are local and accessible community advocates. As we know, pharmacists are one of the most accessible healthcare providers, and 90% of Americans live within 5 miles of a pharmacy. However, what's just as important is really this increased interaction that we see between pharmacies and the community. Some recent research has shown that patients visit a community pharmacy almost 10 times more frequently than a primary care provider. And it's this increased interaction that makes a community pharmacy really an ideal setting for these type of SDOH interventions. Now, pharmacies are providing these services focused on patient social related issues. So these are just a couple examples of what's currently going on in pharmacies to really help out. For example, hand delivery of prescriptions greatly benefits an individual with transportation issues, or providing discount prescription coupons and evaluating the cost of medications really aid those with economic related issues. But now let's dig in a little bit and discuss new staffing models that can be deployed in community pharmacy that could help support an SDOH program, including integrating community health workers or SDOH specialists. So the first practice model that we'll discuss is the integration of community health workers into pharmacies. Now, these individuals are frontline public health workers. They really act as this bridge between the community and the medical establishment. And in a pharmacy, their role could really be multifactorial. A CHW can provide service coordination, counseling, informal counseling, care management, and community advocacy. They could also be effective mediators between patients and health or social services, avoiding many of the barriers that we see with care, literacy, and medical coverage. CHWs have extensive training to really develop relationships as a health coach and speak on behalf of patients when needed. Now, for this model, we've seen pharmacies that train their current staff to be CHWs. There's also potential for pharmacies to kind of employ a CHW part-time or full-time to develop and implement an SDOH program. So from CHWs, we then go into our next model, which is an SDOH specialist model. Now, this is where a pharmacy team member, such as a technician or a delivery driver, is trained with this substantial knowledge of social determinants of health, and they utilize and apply this knowledge to really connect our patients to community-specific resources and advocate on behalf of the patient. Now, just like the CHW, an SDOH specialist role can be multifactorial within the pharmacy setting. There really could be applied where they assess patients' opportunities for interventions, implementing patient plans, referring patients to community resources, and then following up with these patients to make sure not only they attain it, but maintain access to the services they need. So here's just a couple of examples of where an SDOH specialist could come into play. So first on the left, we have a patient that comes to the pharmacy unable to afford their copays for medications, and they leave some behind to pick up later. The SDOH trained technician can engage that patient in conversation regarding medication cost, financial security, and then refer this individual to the pharmacist to discuss their insurance and or a social worker for financial assistance. In our second example, we have a patient that mentions that they have no car to get to their appointments and are thankful that the pharmacy delivers. Now, an SDOH trained delivery driver can engage that patient in conversation regarding transportation concerns and come back to the pharmacy to help refer the patient to either a social worker or an insurance company that can then explore transportation services. So these are just a couple of examples. What we'll move on now are the specific pilot programs that employed both of these models. So at this point, I'll hand it over to Dr. Christopher Daly to discuss the SDOH Specialist Pilot Program.
Thank you, Dave. I appreciate that, and very grateful to be here today with all of you. So yes, we've had a very innovative project. It was dealing with an IPA, which stands for Independent Practice Association, and really looking at a small but significant cohort of pharmacies in the Albany, New York area, part of the CPESN network. And really, this was a recent pilot testing these models and looking into the social determinants of health specialists and how we best go about doing that. And really looking at this model, it was built as a partnership where both sides had key capabilities and resources that they can collaborate together to essentially work through the pharmacist patient care process and help identify patients who may present with social determinants of health, but more importantly, refer them on to the appropriate services to be able to do that. So when we look at the workflow and how this is done within the community pharmacy, what we're really leveraging all of these models on is the excellent relationship that you currently have with patients and their community pharmacy. So when we try to implement a clinical or work care model, we're able to do that because of the interaction and access points that are available to the patients. So when we set out to design this model, and I'm really excited for you to hear from panelists that were actively engaged on this model, is we needed an ability to train the pharmacy staff to give them a background in what social determinants of health are, but more specifically, how do you correctly identify and more importantly, screen for this? And what was developed from that was these innovative trigger questions that were used as a screening tool, but really were observational points that were able to pass it along to maybe a coordinator or pharmacist or head technician that would actually execute the referral for that. And we have listed here pharmacy technician and delivery driver as Dave went over. But this is the model, just keep in mind as we move forward. So it was a collaborative approach with the Independent Practice Association and the pharmacies to sit down and say, well, what are example of what we would term trigger questions or observations based on these different social determinants of health topics that would maybe elevate to something more concerning or something where a referral would be needed or further engagement would be needed at that point. So these really did well to offer the basis of what the outreaches would entail, but more importantly, really kind of queue up for different opportunities, whether it's the delivery driver back to the pharmacist or technician back to the pharmacist or pharmacist to head technician to be able to identify these areas. And as we see from these areas, ranging from food insecurity to utilities, childcare, healthcare costs, transportation, health literacy, and safety. And all of these were different domains that we needed to provide individual training that the pharmacies were able to get together to have specifically for that. So what was actually done in what we would term as the bi-directional referral process? So the pharmacy, being the access point and the one front facing for the patients, would be able to screen using trigger questions, but then what would elevate to an actual referral would be an innovative platform that the IPA provided that they're able to go in, consent the patient saying that these are services available and I will be passing your name along to another individual that will be moving forward. And the IPA had the case or care managers that were able to reach back out to the patient to identify what services are available that they would need to be engaged with and also provide the follow-up as well. So pharmacies, of course, provided their version of follow-up, but it was the actual pairing of the service through this innovative platform that really was the innovation when we're looking at this type of pilot. So as we went through and they did this, we also noticed that there were services that the pharmacy can do, specifically medication related, that became the bi-directional referral, and the Independent Practice Association would be able to refer back to the pharmacy itself. So as we look at this model, it is under a grant model and performance instead of payment model, but we really wanted to look at, can this be done, and can this be done through a process that was set out to move forward. And really going through this allowed the pharmacies to engage with local, regional, state, and other players that they may or may not have had conversations with in the past before. So really that getting that collaborative approach to be able to present these services and referrals to patients as well. And really what we found out is community pharmacies are making a difference, and being part of that value-based care model, specifically when it counts to social determinants of health, is something that we would like to continue to further explore. At this point, I'm going to have Dr. Heather Jarvis take us into the community health worker model and the very important work she's doing in Missouri.
Thank you, Chris. I appreciate that. So my current practice site is at L&S Pharmacy in Charleston, Missouri. And just to go on to the next pilot, my slide is not advancing. If someone could help me out. Thank you. So this project really started in 2019, a couple of years ago. And how this started was a pharmacy driver, delivery driver, was just making their routine deliveries, and they used a social determinants of health screening tool, just a form, to find out if there were any needs that were not being addressed. So what was included on that social determinants of health screening tool was questions like food insecurity and even structural questions about a person's porch. So all of that information was kind of collected on this form and brought back to the pharmacy for evaluation by a community health worker. And so from there, you can kind of determine what other issues are going on and what other referrals could have been made. I know of one that was made. There was somebody's steps that were, not structurally sound. So the community health worker got in touch with the housing department in town and got those steps kind of corrected. So those, how you can kind of see how a community health worker would be instrumental in sort of providing these kinds of community resources to community members. My slides are, 1 second, sorry about that. Okay. Sorry, can you advance the slide? I guess I'm having slide issues. Thank you. So currently I'm working on a bidirectional referral model with the health department. And so how this works is that a patient comes into the pharmacy, they're engaged by a community health worker to see what kind of needs they might have. So for example, this actually recently happened. A patient came in, just was talking to a community health worker about needing to take better care of themselves. They have high blood pressure and they need a blood pressure cuff. Could the community health worker possibly recommend one? And so the community health worker, knowing that we have a blood pressure program at our pharmacy, went ahead and enrolled them into our program. And so from further assessment and working with this patient, they said, hey, I'm really interested in nutrition counseling, and I'm really interested in participating in a walking program. Well, currently we're getting one of our community health workers credentialed to be a Walk with Ease leader. So that will take care of that need. So I kind of will be referring that patient, once we get that up and going, to that community health worker to be part of her class. In terms of the nutrition counseling, well, the health department takes care of that, and they put on classes and also one-on-one nutrition counseling for patients. So that's another referral to the health department. Conversely, when we started this program, we were up and running. The health department also runs it, but they weren't up and running. So they actually referred a patient to us to take care of their blood pressure needs. So that's kind of how you can see how this community health worker bidirectional referral system works between the pharmacy and the health department, in that the community health worker is really an integral part of it. They're the ones that engage the patient and know kind of how to refer them and where to refer them. And so we are getting reimbursed for this service that we're providing through Health Resources and Services Administration grant, and really with our partnership with our local county health department. So I think these are just important to just consider how we're going to be reimbursed and sort of how we can integrate that community health worker into the program. And then our goal of this program is really to generate more reimbursable services and hopefully incorporating more of those community health workers in discovering what social determinants of health can be addressed by the community pharmacy. And now I will hand it off to Dr. Foster. Thank you.
Thank you, Heather, for sharing that important information regarding all of the hard work you're doing in Missouri. And now I would like to walk through some potential sustainability models for these social determinants of health programs in community pharmacy. So our first concept is that this is going to be a layered process where we're going to need to start at the local level with the payers that we more commonly work with to engage them and show them all of the work that our pilot programs are doing and how this can be advantageous to improve the health outcomes of their patients, and then relate that to when health outcomes are improved, that also improves their spending rates for their patients. So we need to start small at our local level and begin that networking process, get a pilot program going with our reimbursement structure, whether it's fee-for-service or value-based. And then once we have that local foundation, we need to expand out through the county, the region, the state, and eventually our ultimate goal is the nation. But obviously this is going to take time, and it's also going to take buy-in from other pharmacies to also start these social determinants of health programs and advocate for community pharmacy reimbursement for these services as well. So one model that's currently available is going to be Z codes, which are a subset of international classifications of disease, 10th revision. Specifically, we're looking at code Z55 through the Z65 for social determinants of health, and they're built on a fee-for-service model. Any clinician who is certified to bill for Medicare services can bill for these codes. And it's important to note that right now these codes are underutilized, which we'll talk about in the next slide, which is where pharmacies can tap into this Z code billing. So right now, there was a 2017 CMS Medicare report that showed that only 1.4% of Medicare fee-for-service beneficiaries had a Z code claim made for them. So this represents a significant underutilization of these codes and ultimately a source of funding that's not being well utilized. Therefore, this may provide an opportunity for community pharmacies to utilize these funds with their social determinant of health programs. One factor that is making things difficult right now that we're finding is that many pharmacies, while they're efficient on the prescription dispensing and billing side, have a lot of difficulties with the medical billing side. So a resolution for this would be to incorporate these services with the local hospital system. And why go to the hospital system? It's because the hospital systems are slowly going to be evaluated on their use of Z codes in addressing social determinants of health, and whether or not social determinants of health were assessed for before a patient was discharged, because if the patient has a 30-day readmission and the social determinants of health weren't addressed, then the hospital is not going to receive full reimbursement. They'll take a penalty on that. So one way in which the hospital systems and community pharmacies can partner is if the hospital system knows that the patient being discharged is going to the community pharmacy to pick up their prescriptions, we can also do a further social determinants of health assessment and workup, and partner these patients with our social determinant of health specialist or community health worker to get them to the community organizations that are going to help them best address the social determinants of health. So it's a win-win for our community pharmacies and our hospital systems. So ultimately, this would come down to more of a fee-for-service contract between the hospital system and the community pharmacy. And that third and final piece that's always important and we always advocate for is to advocate for a provider status. And the reason that this is important is because it's going to allow for more flexibility in medical related claim billing capabilities, which also includes Z codes. So just to sum things up before we move to the question and answer session, we just wanted to reiterate that social determinants of health are the non-medical factors that influence health outcomes. Community health workers are certified frontline public health workers with extensive knowledge of the community they serve, which is why they are an integral part for a pharmacy to implement. We can also use the social determinant of health specialists, which are pharmacy staff members trained in social determinants of health identification and resolution. So the pharmacies can either take one of these two models to incorporate a social determinants of health program. And pharmacy integration with other community resources is crucial for program success. So whether that's the Department of Health, like the Missouri model, the Independent Physician Association, like in the Albany model. Also many other local resources, such as your local mental health counselor, your local food pantry, local social workers, community organizations such as those. And also reimbursement for community pharmacy social determinant of health programs is still being investigated at this time, but we do see that Z codes will be an important part of sustainability for these programs. Before we close, we would just like to acknowledge the following for their contributions to the projects we've discussed throughout the presentation. Dr. Troy Trigstad with CPESN USA, our partners at CPESN Carolina, the Community Pharmacy Foundation, Alliance for Better Health, and all of the patients we have served and will continue to serve throughout this project. If anyone has more questions that we don't get to address today, or you would like more information on joining our collaborative, please feel free to contact either Dr. David Jacobs, Dr. Christopher Daly, or myself. Our emails are listed there. And now I would like to transition back to Amanda with PQA to moderate our question and answer session. Thank you.
All right, thank you to all of you for joining us today and sharing all of your insights and experiences on this important SDOH topic. So at this time, we're going to bring in some additional voices to participate with us in a panel discussion. So joining us today is John Croce, a CPESN of Upstate New York luminary and project coordinator for the SDOH program Pilot Pharmacies in CPESN of Upstate New York. And then we also have Tripp and Richard Logan, who are co-owners of LNS Pharmacy in Charleston, Missouri, and they also co-coordinate the SDOH pilot program arm for their pharmacy. And then finally, Zarina Jalal. I don't know if she's been able to join us just yet, but in case she is, I wanted to introduce her and also acknowledge her role in the project. She is the pharmacy manager of Lincoln Pharmacy in Albany, New York, and she coordinates the SDOH pilot arm for her pharmacy. So each of these panelists has a specific experience in SDOH within community pharmacy, and that includes research, SDOH specialist model that was described previously, the community health worker model, and also Z-code billing. So I would like to remind everyone to please enter your questions into the panel on the right side of your screen, and we will address those with the panel as we have time to do so. So with that, I am going to ask the first question. I'm here related to Richard. I know that you have worked with the Missouri Hospital Association and had some relationships there related to Z-code billing. Could you elaborate for us a little bit more on how pharmacies might be able to partner with hospital systems to receive reimbursement via Z-codes?
To quote Verizon, can you hear me now?
I can hear you. Go ahead.
Wonderful. The interesting thing about Z-codes is, besides the fact that nobody really seems to be paying a whole lot of attention to them right now, is that they are a metric that hospitals and health systems should truly be interested in. There are funds tied to them. If a local hospital system utilizes a population health or whatever department they call it within an institution that is concerned with improving metrics and increasing profits from the hospital, decreasing hospital penalties, they will be interested in trapping this Z-code information that nobody seems to be trapping right now. Our experience with health systems has been one-on-one personal experience because we live in small communities. We know these folks. When we talk to them, we talk to the appropriate individual to to try to gain their confidence and let them know that we can partner with them to trap this type of information, help them not only in Z codes, but to improve their metrics in other ways. And all they really need to do basically is just give us a chance. Once they figure out that what you're talking about is for real, that it can benefit them, that your services can bring money in and not necessarily cost the hospital any money, most of them are very agreeable to at least talk to you about it. So I think basically in doing this for the benefit of the patient, it all starts with personal relationships, whether you have them or develop them with appropriate hospital or health system personnel.
All right, thank you so much, Richard. We have several questions that are coming in related to Z code, so we'll stay on that topic here for a moment. Richard, I will ask these of you, and then Amanda Foster, I will see if you've got anything to add to this as well. So the first follow-up question, Richard, is can Z codes be used with Medicare Advantage plans?
The short answer to that from my perspective is I'm not sure. Medicare Advantage plans are supposedly the holistic Medicare. So I would assume, and you have to understand, I'm just assuming, that Medicare Advantage plans would just be at least as interested in the social determinants of health as regular Medicare. But I do not know the answer to that question definitively.
Dr. Foster or others on the panel, do you know about the answer to that question?
Hey, this is Trip Logan. Also, I was gonna add on to that. One of the values. So I think it's been expressed, and the message is clear that Z codes are currently not being collected. So the next question is, how do pharmacies, not only and pharmacists and SDOH experts, community health workers, collect those Z codes, but then also what value does that Z code have to partners? So I think that to reframe the question was just asked of Richard in Medicare Advantage, there's value to have Z codes collected with all patients, because the more information you have early on about their surroundings, the impact on them outside of just the normal healthcare side of their life, but on the social side and the impact that that's having, which ultimately negatively impacts their healthcare. Collection of that is valuable to all entities. So going back to the original health system question, and I think it was referenced the hospital association's interest in this. These codes are fairly new. They're not something that apparently has been routine for most health systems and other providers to collect and input into electronic health records. And so I think that's where the main opportunity is for pharmacy to participate in serving as extenders to health systems, primary care, other providers to collect this meaningful information. And then, as the slide said earlier, to screen, assess, and refer, follow up with these patients as that extender. And each one of those steps to the plan partners and payers on the line, those all have a tremendous amount of value when these are high utilizers or high cost members of a health plan, Medicare Advantage or otherwise.
And this is Dave Jacobs. Just to jump off of what Trip and Richard are saying, there's just a lot of potential with them, I think we see. I mean, from the data that Dr. Foster showed, I mean, the utilization was only at about less than 2%. And as mentioned, these codes just rolled out in 2015 when ICD-10 started to be utilized. So we've looked at it also, their utilization in the Buffalo area, and we're finding the same thing, that they're really not there yet of being actively utilized. But as mentioned, there's a lot of potential from the parties of how of putting them in place, and then what could be done with them in order to improve the care of the patients overall. Thank you.
All right, thank you, Trip and Dr. Jacobs. Appreciate that insight on both of those Z-code questions. Trip, I would like to ask one more question while we're on the reimbursement topic, specifically about health plans. Have you had any conversations with health plans? Have you had any expressed interest from those plans about reimbursing for SDOH services? How has that gone for you?
At the plan level, there currently are pharmacy delivered SDOH, whether that's food delivery, home delivery of medications by the pharmacy, and other screenings. Those are in play with pilots across the country. Are those tied to Z-codes directly? Not necessarily. Those could be fee for service. Those are also in the per member per month or other payment mechanisms for those. While we're sitting on Z-codes, to me that's the differentiator, because where this should go is once a Z-code is assigned to a patient, that's essentially their diagnosis for their social concerns, then those need to be addressed in the community. Because if a patient's driving 25 miles to their primary care, to their health system, and they live in a different community, their hypertension may be solved in the health system, or they're with their primary care provider 25 miles away, but the Z-code diagnosis will be solved at home. And so that's why we believe it's so important to have these social determinant of health experts and community health workers embedded in the communities, within these community pharmacies where the people live, worship, work, etc. Z-codes are how that's to be tracked, and we think that's the path forward. I think it's we're a little ahead of pharmacies being directly aligned for payment around Z-codes, but I think that's a great conversation to have and where this conversation should be going.
And this is Richard. Just to add to kind of what Tripp said, we spend a lot of time talking about Z-codes, but there's a really good reason we spend a lot of time talking about Z-codes. Because if the patient Tripp was referring to, who's receiving blood pressure treatment at 20 miles away at his physician's office, can't get to a physician's office for an appointment and suffers a stroke, then, he's got an ambulance ride to the hospital and therapy and a stay in hospital and treatment. And these people are really expensive to the system, which is where the realization and the utilization of Z-codes really saves the system money, and why they're very important, and why we think that as pharmacists, seeing a patient 10 times more than a PCP, we can really make a large impact there. Just kind of my 2 cents worth.
All right, thank you so much for everybody's input on that. Let's switch topics slightly to some more practical considerations. We've got a number of questions coming in about how do you implement these models in the pharmacy. So I want to combine 2 questions into one here. The first is related to how, and Dr. Jacobs, I'm going to toss this one to you. How can a pharmacy best decide if they should utilize the SDOH specialist model or the community health worker model? And then once they make that decision, is there a good place to go for training materials, either one of those models? What recommendations do you have for that?
Yeah, thank you for the question. And let me take the second part first. So this team has been working over the past probably almost around 2 years now in the development of a toolkit related to this, where we go into details about social determinants of health, discussing more about community health worker models, social determinant of health model, implementation plans, and then providing some tools that could be helpful for the pharmacy that is interested in doing this, and things that they could take and then adapt and put into place. So we're really excited about that toolkit. We're hoping to get it just about completed, or at least the draft completed, where we could then provide it to the public in the next few months. And that could be a good place to start. That could provide some information about it. To answer your first question, which approach would you take? I think it's really just thinking about the program that you want to put together, maybe the reimbursement that's potential, whether it be grant funded or not. The SDOH model may be a first step into it, because it's utilizing sort of what is in-house already with your staff and training them a little bit more in this area, and then seeing how the program goes, potentially expanding that to a CHW model. But that doesn't mean you can't just go all in and try and work with the CHW model. But we could definitely see maybe the SDOH being that first step into getting into doing these type of SDOH programs.
Amanda, if I may, we were one of the sites or one of the projects that tried to use the SDOH specialist model. And we felt we had some really good success with it. There were some inadequacies that we had to address, but it was much easier for a pharmacy to incorporate the qualities of a community health worker than bringing a community health worker in and co-training them as a pharmacy technician. And both models, I think Tripp and Richard have done something a little bit of both. They've trained their own staff as community health workers, and they've incorporated community health workers into it. In the Albany project, with the grant funding that we had and the ability that we had with the Unite Us Healthy Together platform that took care of a lot of the mechanics and operational aspect of it, it allowed our staff to do what they've naturally done all along, which is be in tune with their patients. And really the part of the training was being able to identify those trigger events and then relate it to how I can use the power of a reporting tool with Youth Healthy Together as SDOH specialist. And it flowed well in an incorporating workflow on a pharmacy bench counter.
This is Tripp. I'm going to echo what John said. It's really, community health workers are local liaisons that are experts in their community. And really, it's a local decision on how to do that. And Richard and I have approached this from a couple different directions over the last several years. And right now, we have, I think, 6 dual trained pharmacy technician community health workers on staff in our pharmacies. And we're training another one right now going through community health worker coursework. We felt we looked at this from several different angles, and we felt from a sustainability standpoint, it made the most sense for us to cross-train existing staff, because we felt that there were 2 approaches, and John put his finger on this: to either acclimate a community health worker to the pharmacy landscape and fully understand what it's like to work within a pharmacy, or vice versa, to take a pharmacy technician who is familiar with pharmacy and expand their knowledge base on social determinants of health and the local community and become that expert in the local community. And we just felt in our practice that the least resistance was cross-training existing staff. That way we kept them there, they were already there, and they just had additional training in that course. It is an extensive course. What we sent our staff through 12 or 16 week, I believe, at a community college or a satellite campus of a university, and it's available online as well. That's what we chose to do in Missouri, and that's also recognized with a state registration, which is also factored into our decisions.
One of the things that we're trying to do in building on our first pilot with Alliance for Better Health has been a tremendous partner for us in the Albany market, because we felt that there were training opportunities and coaching opportunities with our staff that just wasn't available without being shoulder to shoulder with a community health worker. And so we're looking to get grant funding to have a roving community health worker, whether it be a community health worker who's already registered or one at a local college that is training to be one, and have them circulate through the pharmacies on certain days to work side by side with technicians and show them how to get past the apprehension of how to approach a patient. They want to help. They don't know how to ask the question of, when was the last time you ate? Why haven't you eaten? And those can be difficult questions. And that was some of the barriers that we saw in our initial pilot of, you want to help, what's the right way to help? And working side by side with someone who is trained in that process, we think would get us to the next level and have that. So we're interested to see where they may go with this if we can get the funding for it.
Thank you, John, for sharing that with us. I appreciate everybody's perspectives on this. I wanted to turn to a couple more practical considerations. And Heather, I'm going to toss this question to you. It's actually kind of a two-part question. The first part is, how have patients reacted to being asked about these types of questions? This probably is something that they're not used to. If you've got someone on your pharmacy staff who's starting to have different types of conversations that they haven't before. And then second piece to this is there any concern, or have you identified a need or a safety need in particular that you haven't been able to meet, and have you had to try to kind of figure out how to handle that for the best interest of the patient?
Okay, well, thank you for that question. I would say that we're very fortunate at L&S Pharmacy to have technicians that have been with us for 20 plus years. So they're, in my opinion, sort of already community health workers or community members that just happen to work in a pharmacy. So in a way, they're kind of already set up to being optimal in providing whatever service a patient could come in for, because they already have a relationship with that patient. More so than just like, I'm a community health worker, or I'm a health worker and I'm, trying to talk to you about whatever issue it is. It's more of like they're a friend, they're a community member. So we've been very fortunate. So, I mean, I've overheard general questions that our community health workers pose to patients, like, how are you doing? Oh, I heard that your mom's not doing well. Is there anything that you're struggling with? Just very casual conversations, a lot of them. I think, looking at them, I don't even know if they realize that they're doing like a screening, but that to me is a screening. You're asking about the patient, you're kind of like gathering information about what's going on socially in their world. So we're very fortunate. And I think utilizing, especially your technicians that have been around for a really long time, I think would actually, I mean, they're probably already community health workers, and you just don't even realize it. There's always those technicians that are kind of know everybody, know what's going on, that kind of thing. So just utilizing those technicians in particular, but maybe they don't know where to refer that patient. And so I think that's where that community health worker training is very valuable. And we're even working on a curriculum right now for that dual technician community health worker role. So stay tuned for that. So I think that would maybe help some of these technicians develop questions and kind of like how to pose those difficult questions. So like I said, we're very fortunate in that I don't think that's a big struggle for us. But I think in other pharmacies that would be a struggle is just maybe additional training. I mean, I, for one, even during this year went through like a boot heel counseling session where they just kind of, talked about how to approach talking to someone with depression or suicidal tendencies. I mean, those are difficult questions. And I think just finding out where those resources are and then referring to those resources as they come up. So that's kind of the first part of that question. I think the second part of the question was to identify safety needs and then figure out how to provide that. And I think that's where our community health workers really shine, because during that coursework that they go through, they really put together a community resource binder, and it's supposed to kind of have everything in there that a patient might be referred for. So transportation, there could be counseling, there could be housing. I mean, all of this stuff is in this binder. And so they put that binder together through their coursework. And so I don't think I've really come across a scenario where a community health worker would not have been able to provide some type of direction or help. If they themselves don't know the answer, they figure it out. So I would just say they figure it out. And if they can't figure it out, they usually bring it, to Tripp and Richard are really great at figuring things out or referring elsewhere as well. So I think just utilizing your resources, knowing your community, knowing what's available, and then even knowing on that end, just knowing outside the community to see if maybe there's someone in a neighboring community that could provide that service or that help.
Amanda, Serena is on the call, but she's not sure how to unmute from her phone. Do you have that power?
Let me see. I do not see her logged in. So I apologize. I'm not certain how to do that for her.
No, it just, she, being in our pilot, she was a practitioner on the ground with her staff in a much underserved area. And she would have had, I think, some good input to complement what Dr. Jarvis was talking about. We're a little bit not as mature in the community health or, CH workers and social determinants health as the L&S pharmacy. And so we found that it was much more of a coaching and training for our staff, very much in tune with their patients. But again, getting past that initial apprehension of how to start that dialogue. And just the way Dr. Jarvis explained it is, hey, how you doing? What's going on? I think sometimes fell into a more screening assessment question and going question by question rather than incorporating it into a flow. And I think that's just the maturity of the system that you're seeing what the Logans have been able to do and what we're attempting to do here in Albany. I was just hoping that she was able to talk and share with it. She would have done a much better job than I.
Okay, thank you, John. I just sent her an audio pin. Hopefully she'll receive that and she might be able to put that in so we can hear her audio.
Thank you.
Yes, you are welcome. Tripp, I wanted to ask a question of you about from a quality standpoint. So when we are thinking about these services related to SDOH, what aspects would you be comfortable having measured and then compensated based on quality and outcomes? So how do we show the positive outcomes and show that this is a quality of service provided to patients?
It's a well-timed question. Our clinical director and I were having this conversation about 2 hours ago in the office. One of the things that we're measuring now, we have been for the last couple of years, is the pharmacy referral. And if you look at the value of a pharmacist embedded in the team, in the healthcare team, there is typically some metrics that look at, okay, how was this savings? How was this value attributed to the pharmacy and the pharmacist's interaction with the patient, or the value that they provided? How is that specifically attributed to the pharmacist and the pharmacy? The next question is, when you're in this world, and so Heather's example was phenomenal in describing what this looks like in practice once staff is called. Hey, how's it going? Pretty well. Yeah. How's your mom doing? Okay. Her blood pressure's real high. Oh yeah. How's her blood sugar? Well, it's doing okay, but it's been creeping up. Well, why? And then you find out that she can't afford her medicine, or that she can't get to the endocrinologist for a refill, for a prescription. So those things are so valuable. And measuring referrals and then the results of those referrals. So one of the great things about our engagement with HRSA, and thanks HRSA for helping us in the pharmacies in Southeast. We've got 11 counties worth of pharmacies working with public health entities in Southeast Missouri. And one of the things we're measuring is the impact of that referral. So pharmacy staff engages patient, finds need, refers to maybe pharmacy service internally, maybe to public health, maybe somewhere else. And those are very valuable things. Outcomes as well. If we're referring for diabetes services, diabetes self-management education, immunization metrics, those are all things that we can either have a community health worker refer to. Patient needs a flu vaccine, refer to pharmacy, refer to the public health department. That's a great metric. I would love to be measured on that. So the sky's kind of the limit here. The problem is, and here this is I think very important, and this is where we landed this morning and yesterday when we were talking about this. Unfortunately, when you're talking, PQA is is the expert organization around pharmacy claims-based population health metrics. We're talking about local patient metrics. And when a social determinant of health expert or community health worker engages with a local patient, there are about 5,000 variables that could lead us down a path for the right solution for that patient. And it's hard to measure that on a population health basis. But measuring those referrals and successful acceptance of that referral and the outcomes past that's where we're playing right now. And I think that's going to show the true value of what the community pharmacy, the local peer-to-peer relationship of that social determinant of health expert, community health worker in the community working with the patients will be. Population health wise, we've got some work to do to get enough pharmacies engaged in these efforts to really move the needle on some of the more common metrics. But I've got all the confidence in the world that that'll get there because we've got enough stories, enough small number data, and the expansion of what's going on right now in not only in our region but in New York and elsewhere is showing that this impact, this is positively impacting patients, and COVID only threw gasoline on that fire because patients are significantly more remote now. They're significantly further away from their providers. And so as that's opening back up, we're fearful that there's going to be an increase in chronic disease that's been maybe not managed to goal over the last 12 to 18 months. Which means it's even more important for local access to somebody that your liaison to the healthcare system and social networks around that community.
All right, thank you so much, Trip. I wanted to check to see, Zarina, are you able to hear me? John, have you heard if she was able to get online?
No, I have not. I pinged her and I haven't gotten a text back yet. Sorry.
Okay, nope, no worries at all.
Okay.
I think we have time for just one more question. We've had a little bit of interest in the questions here about the trigger questions. So Dr. Daly, I wanted to ask about the trigger questions that you mentioned earlier on. Was it SDOH specialists that are using them, the entire pharmacy staff? How does training work around that? And do you have anything else you'd like to add about the trigger questions?
Certainly. Thank you for that question, and I'll definitely welcome John's input here as this was a collaborative effort. So when we were looking at the level of, and as others on the panelists have explained, when you look at what constitutes the level needed for this to, go to the consent and then eventual referral process, that might take multiple steps. It might take multiple engagements. So the whole effort and motivation around the trigger questions are what are observations, what are day-to-day things that a technician, delivery driver, as Dr. Jacobs mentioned, the multiple 35 on average times that this patient, may engage the pharmacy. And as Trip mentioned, COVID's completely changed the pharmacy model in a very positive way. It expanded the outreach, it expanded the value of these enhanced services that pharmacies have been doing for decades and can continue to be, pinnacle members in their community. So when we look at this, we really looked at the different topics and tried to develop questions, whether, if there's an observation, so if there's permission from either the delivery driver or individuals dropping off medication to enter the home and things that they might have. So it could lead to something as simple as just, phoning back to home base, saying, hey, I noticed this about this individual, would it be great to reach out? Or, if they did something, they could engage the patient right then and there and say, hey, X to the technician, definitely has some resources to be able to help you. Do you mind if we could set up a referral or a time where we can reach out and investigate a little bit further? And that really was, that flexibility allowed maybe some of our pharmacies that were originally hesitant or originally thinking this was outside their scope or their confidence to say, yeah, we do engage on these levels and we are able to confidently do this. And we'll definitely make mention about these questions and ability. Pharmacy continues to want to receive education and individuals in there to be able to understand their patients more. So we definitely see this as a great opportunity to expand education and only developing more of those trigger questions or more of the opportunity for patient engagement. John, did you have anything more to add on the relationships and the development of this?
Yeah, you did a very nice job with it, Chris. Thank you. But, we also looked at it where, working across 8 or 9, 10 pharmacies, there's just always a certain amount of turnover on drivers and other personnel. And they're really the eyes and ears outside of the store. And to get them up to a point where they can do an active screening questionnaire, 10 questions, log on to the Healthy Together platform and complete it all the way through, we felt was going to be an unsuccessful ask. But if they're making a delivery and the person states, yeah, I'm not going to be here next week because I can't pay my rent, or they're there and they see children being unattended, they don't feel comfortable acting on it, but they do certainly feel comfortable bringing it back to the pharmacy, bringing it back to the technician who has been more trained in this, that then they can do the outreach and do follow up on that. And we use trigger questions, but it's really trigger observations. It's anything once you get that person up with a minimal amount of training to say, train their eyes and ears to look for these triggers, whether it be verbal or, but the house is unclean and dirty. Maybe the person's asthmatic, and that we can effect a change that can be proved that we can reduce healthcare costs and increase outcomes because of that observation. So we try to use those trigger questions to take some of that burden off those newer personnels or people that don't have those skill sets, but could still be a valuable source in leading us into social determinants of health situations.
Okay, thank you, John. It really is about treating the patient holistically and using all of our powers of observation. So thanks for describing that for us. That is all the time we have for questions today. I wanted to thank the entire panel again for taking time to present your work, to share your thoughts and your experiences with us. And then I did want to share in closing that the PQA annual meeting is coming up. We will be online from May 11th to the 13th. Our meeting this year is going to feature 36 speakers. We will have educational sessions that address top issues, emerging trends, and topics like medication quality, measure development and implementation, and then also care transformation and technology. Registration is open. We do have an early bird rate that does end next Friday on April 30th, so I encourage you to register today if you have not done so already. And then once again, I would like to thank PerformRx for being an educational sponsor of this month's Quality Forum. And finally, our next Quality Forum webinar will be on Thursday, June the 10th. The topic will be the voice of the patient in medication therapy management. And then I would like to remind all attendees to answer the brief survey that appears as the webinar concludes. And then one more reminder, the recording and the slides will be distributed within the next week, and those will be made available on the member resources section of our website. Thanks to all of you for attending, and have a great day.